I'm using this.
Great.
Hopefully you can all hear me. My mic is working, is it? Okay, fantastic. As I've just been introduced, I'm part of the Accessible Information team at NHS England. And we're a very small but fully formed team of really myself and Kevin, who is also with me here today. And our role really has been, once the standard has been developed, was actually to start taking forward bits of work and things that will help people to support implementation. So some of the things we've been doing is running some events around the country, trying to get out and talk to people, raise awareness of the standard, because I'm conscious a lot of people are still not aware of it, but also to try and understand what the challenges are out there that people are facing and see what we can do from the centre to help with that, because it's very much a balance between actually the standard, which is a framework, and you implementing it at a local level within the context of your services, but actually what we do centrally, where we can, to effect things that will help you and to stimulate sharing. So it's fantastic to be in the room today with you all, a real opportunity to share knowledge, expertise, hopefully find some of those solutions. What I'm going to do is whiz through a slide pack that we put together for the events to try and make sure that we're all on the same place and on the same page, and to try and, I suppose, just make sure we all understand exactly what it is that we're being asked to do, why we're being asked to do it, and actually some of the things that are there that will help in this. So the background is, it was actually developed with partners, so it wasn't just NHS England who had this bright idea. Actually, it's been stimulated and come from the people that this most affects. So we've been working with organisations like RNIB, Action on Hearing Loss, SENS, National Care Forum, a lot of people like that know that people out there aren't getting information and aren't being communicated with in ways that is accessible to them. And under the Equality Act, we should be doing that. So the standard itself was developed, I'm told it's been about 20 years in coming, this. So it's not something that's a great idea recently. Actually, it's been wanted for a long time. So we've taken this opportunity to actually put the standard in place, working with our partners, to look at providing some direction in terms of what do we mean in terms of accessible information, and what do we mean in terms of some communication support. What are reasonable adjustments that we need to make? Who does it apply to? It's basically, because it's an information standard, it is mandatory. There are no get-out clauses. There is no, we're slightly different, we can't do this. If you provide health services or adult social care, and it's publicly funded money, it's part of the Health and Social Care Act, you are required to comply. So it must be implemented, and not implementing it will leave you open to legal challenge potentially. But it's actually about those complaints you get, the reputational damage. It's that side of it that I think is sort of more problematic for us as organisations. Why do we need it? We shouldn't need it. The Equality Act exists. There is a legal duty to do this already. I think what we are finding is that people haven't necessarily understood what those reasonable adjustments are for this particular area where people need help and support. So these are, it clarifies in effect what needs to happen to meet the needs of these people who at the moment frankly aren't always getting the services that we should be providing for all in a fair and equal way. And we know that service users with communication needs often receive information that's not accessible. And we know that they're not always supported to communicate. So a couple of examples that I've heard is there was a chap that he was completely blind, and he kept getting letters sent out to him from his GP asking him to come for appointments. And he kept repeatedly saying, I can't read these, I'm sorry, I'm blind, I can't read a letter. And he asked many times, and this went on and on and on. He said, and the only way, suddenly the penny dropped, because he actually responded to them in Braille. And that suddenly made them realise, actually, we can't understand this. And it kind of it helped them to realise what they needed to put in place to help that particular individual. And another interesting one that I heard was in an acute setting where they said, well, we do the information, you know, we do the accessible information, so we do this already. Whenever the doctor has something important to say, we always make sure there's an interpreter, a BSL interpreter available. And they'd not really realised that maybe the patient at other times might have something important to say. So I think it's just, it's thinking beyond what we think is reasonable, and actually the whole point behind the standard is talking to those individuals who have the needs, understanding their needs and actually responding to those needs. So the aim of the standard, I've sort of just talked around that. There are the two sides to it. It is about the information we provide and send out and produce, about that, how we make that accessible. But it is also about communication support. So it's how we communicate with people in a way that's effective for them. When we think about implementing the standard, it's a whole system, whole organisational approach really that's needed. So we need to look at our policies. We need to look at our procedures. So how do we currently do things? How could we change those to meet the standard? One of the biggies is human behaviour. There is a need for us all to think differently when dealing with people who have communication needs, and there are some simple and effective things that we can all do that actually can really help meet people's needs. And it's not necessarily rocket science. It can simply be acknowledging, asking and understanding, and perhaps sending a letter by email where that individual can interact with it using a screen reader. So there are a whole load of technological solutions out there that we may not know about, but actually the community that we're trying to reach do know about, and they can help us to understand how we can meet their needs. And we as staff across our organisations need to make sure that we all understand why it's so important and the impact it has on these people's lives. And I'm sure Hugh, when he joins us, will be able to give you a bit more insight into that. And then the favourite one, which is I suppose why a lot of us are here today, is electronic systems. Clearly we need to make some changes within electronic systems. And I suppose we're fortunate that we have good electronic systems within health. The standard also covers adult social care, and they're not always so fortunate. But actually that in itself is a problem because our systems don't always talk to each other. We have challenges in terms of moving between organisations and sharing information. So again, hopefully today we'll try and iron out and understand some of those challenges, see what we can do centrally, but actually some of the solutions are there. It's just about finding them and sharing them. The standard itself sets out a consistent approach to 5 different things. Basically, what we as provider organisations need to do is to identify who has communication needs. We need to be able to record that in a clear and consistent manner. We need to be able to flag it, highlight it, shout from the rafters so that people can react and respond to that information in advance of that individual presenting or when they present, so we can adjust what we do. We need to share that information. And one of the things, it's brilliant to be here today because one of the things I keep hearing is we should be catching this information at first point of contact, and obviously primary care is one of the first points of contact for most people who interact with health services. So actually, if we've got that information, what we really need to be able to do is try and share that information when that individual moves through the system into other organisations, so referrals into secondary care, for example. So again, we've got people talking later today, so hopefully we'll understand better how some of that can be facilitated or help. I do apologise, am I standing in front of my presentation? And what we actually need to then be able to do, which is what makes this standard slightly different from the other information standards, is to meet the communication needs of users. So there's an automatic assumption we have to produce everything in Braille. Actually, there's only a very small proportion of blind people who actually read Braille. What they are much happier with is using their own assistive technologies to read letters to them if they're emailed in an electronic format, for example. There are many ways around this that are not necessarily rocket science, just printing larger font, audio files of a letter, so actually recording it on an iPhone as an MP3 and emailing it to someone. There are quite some simple solutions. It doesn't have to be rocket science. And having spoken to people in primary care, I was talking to a lady yesterday, and she's panicking about implementing the standard, and she said, well, I can tell you who all my patients are that have communication needs, and we send large print, we do this, we do that, we do all that. Why do I have to do all this? And it was sort of, but you are implementing the standard. What you need to do is just make sure it's done in a standardised way so that that is being shared. So I think many of us think we haven't started, and I know there's 31% on there when we were looking that said they hadn't started yet. You're probably doing some of this already. So actually think about where you are, and it's about taking yourselves forward from there. It's not you're not starting from a zero base on some of this stuff. Because I know you do that already. I know you are responsive to people's needs. What we need to do is be consistent and make sure we're responsive to everyone's needs. So that framework, those 5 things, really, the steps are asking people if they've got those communication needs. And this is about recording their communication needs. It's not about recording their disability necessarily. It's about what the communication needs are. It's about recording them in a clear and ambiguous and a standardised way, so that if it's shared in your organisation, actually it's the same understanding in another organisation where we are sharing that information. That we alert, flag and highlight. Today we're going to learn, hopefully, I suppose, about how we do that within electronic systems. But actually, if you find it easier to use a non-electronic approach, or you have a flagging system already in place, you know, sort of big green highlighter pen or sort of stickers on patient records, for example, those work as well. It's not mandated from the centre that this must be done in a certain way. It has to fit with your own situations, your own policies, your own procedures, the way you currently operate. It's about taking that and making it fit to the standard. Sharing information, that's the bane of everyone's life, and hopefully some of the discussions today we'll understand and tease out some of that, and maybe find what the workarounds are, what the solutions are, and acting on it. Again, acting on it is the one that people think is really challenging. We're going to suddenly have to pay for all these interpreters and translators and do a lot of printing and having stocks of things. No, it's about individual needs. So find out what your local individual needs are, and then how you can be responsive to those. The impact of the standard, really, in terms of the impact on the patients, the service users, the carers, the parents that are at the moment not getting this sort of communication effectively, they should hopefully be able to make contact with and be contacted by our services in accessible ways. It will make such a huge difference. I speak to people and understand some of the dreadful challenges that they've faced in sort of how they receive services. They should be able to receive correspondence and information in an accessible format, including alternatives to standard printed formats. But if you have standard printed formats, do make them accessible so that you are sort of anticipating needs. Often people find that making them more accessible for this particular people who have communication needs, it makes them more accessible for the rest of us as well, who don't like the jargon or find it nice if it's well laid out and presented in a way that's easy on the eye. So there are things that we can do to help meet everyone's needs right up front. Being supported by a communication professional at appointments, that can enable effective two-way discussion. That can really help to enable individuals to be involved with and make decisions about their own health and care, to self-manage more effectively, to actually feel that they can be responsible and have the same rights and privileges that people without a communication need don't really think about. We take it for granted. So it's actually about giving them those same opportunities, about really quality of access. And also, receiving support from health and care staff to support effective communication. So sometimes that is just as simple as understanding that if someone lip reads, for example, if you look at them when you speak, they can understand. And I've heard stories of, you know, doctors who sort of talk and type, and the lip reading's just not feasible. Actually, just understanding that can mean you can, there's nothing put in place, just talk to the person face to face. There are some really simple ones. That's one of the things that we'll be putting out, is some guidance about those kind of simple changes that will help in this area. Timescales. This is the bit where I usually dodge down and avoid the flying tomatoes in the room. The standard itself obviously came into being last July, and a year was put in place for it to be implemented. So the organisations were expected to have a plan for implementation by September. By April, all organisations should be able to identify and record information about people's communication needs. So that's a sort of a stage. It's the kind of, from April, we should be starting to get a picture of what people out there need in terms of communication. And obviously the dreaded 31st of July deadline date when full implementation should be achieved. It's mandatory. I can't say that often enough. People say to me, oh, well, can we have a bit of an extension or a slippage? It's mandatory. Having said that, NHS England is not monitoring it. This is a legal requirement. It opens you up for legal challenge. We don't need to monitor it in that way. But I do know that organisations like CQC, for example, will be interested in looking at this as one of the markers. They'll be interested in that. Health Watch will be interested. And certainly, and I'm sure Hugh will say this later, the organisations that represent patients and clients and users of services, they will be very interested in understanding where people are up to and how people are moving forward. And my guess is that actually the majority of people are working towards full implementation, and that will be acceptable, and it's about managing those expectations with your voluntary and community sector representatives, and who can communicate with the groups effectively, with yourselves and on your behalf, to try and help them understand, you know, don't all turn up on Monday, we won't be ready to do that, but actually we can take your information at this stage. I think that's a real key message, is if you're not engaging with your local organisations, please do. We did have some pilot sites that implemented the standard for us, and I think 3 of those did come from a primary care background. I've put some top tips in here, and I don't intend to go through them all individually. I'm assuming and hoping that the presentation will be shared with you all. But those top tips, I think, apply to most organisations. It is things like, as I've said, using and developing your existing systems. Please don't throw the baby out with the bathwater. Don't start from scratch. Look at where you are and evolve to meet the standard. Try and use what's already working effectively. Terminology that's meaningful to your organisation. Don't rewrite it to try and fit with something. Obviously, there's a need to be standardised and work across and between organisations, but within that context, obviously work with your own staff, your own service users to use language that's meaningful to you and them. An additional time for interactions, that's one I think in primary care it's always a challenge. Very often, I know that practice managers very often have a pretty good idea about some of the people that will be affected by a communication need. So actually, that might not necessarily mean giving everybody that comes through the doors a longer discussion opportunity, but actually it might just be for certain individuals. You might be able to identify who they are and actually just do it by exception in a few different cases, so that people can actually have that time to talk through their needs and to understand what they are. And again, last one on this is collaborative. Work with your third sector voluntary organisations who are experts in this field, who represent the people whose needs you are trying to address. They will have answers, solutions, ideas. They don't necessarily want to be presented with what you think is the right way to do this. They can be part of that solution. So again, I would really strongly encourage you to, where you can, work with the people who are the experts in this, the people you are trying to really, as I say, address their communication needs. We are producing central guidance, pulling together some templates and resources. These are delayed. We have had some problems in terms of, as a national organisation, it's quite difficult to actually get information out from the centre. We're very restricted in what we can do. We have a plan of action. Kevin is on the case, and we will be getting some of this stuff out to you in due course. So we're hoping to be able to publish and signpost to the guidance, the resources, as they come available. And hopefully what I'd like to do is, perhaps if you're all happy, is to ensure that your contacts are on our emailing list so that we can contact you directly. Hopefully we'll be able to share that, make sure we can get information straight out to you. One of the challenges has been information going out from the centre, goes in at the top, trickles down and lands on some poor soul's desk, and actually we can't reach that person directly. So these opportunities are really good for us to have a conduit straight out to talk to you and to build that network and community, to talk to each other and help each other. We've also commissioned some e-learning. We've got an e-learning module that's being developed in partnership with Health Education England, so it will sit on the ELFH site, ELF. Whilst that's being developed, there is a Disability Matters website that has got some e-learning on there as well that is relevant and will be helpful, I'm sure. And then there's, again, a list here of the kind of guidance and fact sheets. It's the stuff that we said we'd produce in the implementation plan, and it's really some of the content of the standard. It's clarifying that and sort of taking it out and expanding on what some of that means. We have got frequently asked questions that come up at every event we ever speak at or go to. We've also got some of those. Again, I'll take the opportunity, if I may, to share those through this opportunity with yourselves, so that you can see some of the answers and what some of the responses are to the frequently asked questions that we get. Hopefully some case studies. What we'd like is to actually get some examples of where this is working well, where people have overcome the huge challenges that this is presenting. And I'm not standing here saying this is easy. I know I say it's not rocket science, but I know it's not easy for organisations that are trying to implement it. I know there are some hurdles to overcome. And examples and templates. We want to be able, if somebody's produced a fantastic patient registration form that works for this effectively, and we can share that, we will. So if any of you out there have anything that you think, actually we've solved that, we've got the how to do it guide, please, if you would be willing to share it, get in touch and we'll try and facilitate that, either through this group or through the wider resources. The summary care record, I'm going to skip over that a little bit because I think we've got the chap coming to talk later on summary care record. But the functionality is there. It sits in the summary care record. I won't steal anyone's thunder, but it can be done. We can record that information effectively in there. And the other thing, I wear a second hat, which is the information standard. And actually, one of the things is we put a lot of information out there for people. We're trying to make it accessible. Let's make sure it's good quality as well. So actually that the quality of content is there. The information standard, it's a voluntary scheme. If anybody is interested or wants to know more about it, please get in touch with us. The addresses are on the presentation. And if you want to get in touch, find out anything more, please do get in touch. We've got a generic email address on here that you can use. If you're getting in touch with any of us personally, if it comes to me, I'm swamped with emails because every event we go to, I get inundated with emails. So I'm not as responsive as I should be at the moment, but Kev's very good. So between us, we'll try and get back to people as we can. So hopefully that's given you a flavour of where we're up to and what's coming in terms of resources.